Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. Mark Parrino welcomes participants.
Good morning. I'm very impressed that so many of you are up at this time of morning with or without coffee, so I appreciate your attentiveness. My time with you is brief, so I will make the most of it in the next half hour. First, I'd like to express my gratitude to Catherine Cates-Wessel, as well, a partner to us from the American Academy of Addiction Psychiatry. AATOD is part of the ORN network. We find this to be an incredibly helpful technical assistance resource to our entire field. Also, AAAP is a great policy partner to AATOD, and I'm grateful for that as well, because we have a lot of very dynamic policy issues that we're dealing with at the present time, which I will mention. I know that you've heard from a number of our associates. You've heard from Brent from the National Commission on Correctional Health Care. I'll reference their document of October 2018. I know you've heard from my associates at the Legal Action Center, Gab and Sally. We work very closely with them. In fact, AATOD's office in New York is co-located with the Legal Action Center, which basically tells you how close our policy coordination is. And to Linda Hurley and her associates at Kodak, who've done such an incredible job in helping to provide highlights of how medication-assisted treatment can work hand in glove with corrections. We see corrections as an essential partner. I'm grateful that so many of you are here. From my point of view, doing the work of the past 20 years, and I'll get into that, this sort of issue represents an inflection point in how two different systems can work very closely with the mutual interest, frankly, of getting inmates what they need, the treatment that they need, and then a referral to an outpatient or inpatient facility, as the case may be, to continue that need and progress. I know that Linda and her associates have documented, and I know she presented to you yesterday, but if I'm right about this, that you have a 60% or so reduction in post-release mortality and about a 55% reduction in recidivism. That's the way it should be. I think that we can improve on those recommendations and those data as time goes on. But we are at a very important point in our history. And I'll just say that the reason I wasn't here earlier is because I was in Washington for the last several days. Not, thank God, not anywhere near those hearings. But I was there dealing with the United Nations Office on Drugs and Crime, World Health Organization, and our State Department. They will release, mostly WHO will release at the end of March, the new international governing standards for drug use treatment services. This is a worldwide issue which WHO and the United Nations will actively promulgate. I'm a part of their working group, so we'll promulgate that in the United States. And there are several foundation issues which relate to some of the questions that were asked and answered this morning. One question is the importance of protecting confidentiality. It's a bedrock standard in these new international standards, and there are reasons for that. The next is the bedrock standard of when medications are used to treat opioid use disorder, that clinical support services should be provided. I understand the argument of you want to provide access to treatment, and that is so. But after you provide access to medication, what else are you providing access to? Medication alone is not considered effective treatment for this disease. To be clear, and there's much research that's been done on this over the past 50 years. And I'll note that when I was at a meeting at SAMHSA and NIDA headquarters about 6 or 7 months ago, Peter Katusian, who serves as the sheriff of Middlesex County in Massachusetts, made an excellent point. And he said to the federal officials at the time, if you're not really encouraging or otherwise promoting the use of clinical support services once medications are used, how are you treating comorbid conditions that this particular population has? How are you treating hepatitis B and C? How are you treating psychiatric disorders, anxiety, and depressive disorders, which have a big prevalence in this population? How are you dealing with trauma? And I'm looking around the room, which had many other sheriffs, my counterparts at other national organizations, and drug court judges. And I'm just looking, I said, by the way, does what Sheriff Katusian said summarize your point of view in dealing with this matter? And the answer was yes, to what I perceived to be slightly anxious-looking federal officials at the time. So I will say to you, in building a system, and I recognize that to many of you this is new, but it was inevitable. And I think that now you are at that sort of moment of impact. So learn from the research, learn from what has been done since the mid-1960s. We know a great deal about opioid use disorder. We also know a great deal about the medications that are used. And I'll just say this, because I'm sure it's been covered before, but to underscore the matter, the medication that's selected must be used wisely for the individual patient, based on the individual needs of the patient. There are three broad medications that are used: methadone, buprenorphine, and naltrexone. And there are many forms of each one, whether it's pill, film, or injectable. And NIDA will begin a 3-year study in corrections looking at how these three medications are being used, what are their retention rates, what are their comparable values, in addition to the support services that are provided. And that will begin very shortly. And that will be the first time that all of these medications are compared in a correctional environment. And that should be helpful in providing future guidance. So with that, let me show some of the slides. This is obviously the funding slide from ORN. I show this slide to you only because it provides an historic reference. This was actually published by the New York Times, and it looks at how the map of the United States changed in 10 years from 2004 to 2014. The 2014 is to the right. It's an active descriptor geographically of how we got to where we are at the present time. And you can see on the right, when you look at the darkly shaded parts of the map, that indicates a much more profound issue of misuse of opioids. And I will give you summary slides from a radar system. AATOD manages a system of 75 reporting OTPs in 30 states. We've been doing this since January of 2005. We've collected enormous amounts of data, and we had trend data in 2010, which we shared with federal agencies, which have jurisdiction in this area. And the key finding was that at that time, 45% of newly admitted patients reported misuse of prescription opioids. Now, when I presented that to the federal officials, the answer was, that's nothing, we know this. So I said, well, let me give you a piece of data you don't have. Of that group, 30% are injecting their prescription opioids. We found this in 2009 and 10 after 5 years of cumulative data. And when one of the officials said, what do you make of that? I said, something has twisted and changed in this country that so many prescription opioid users are now injecting that. It's presaging something to come. I can't tell you when. We think it predicts a major heroin epidemic and potential shifting out from that. Sadly, that was true. And it would become much clearer probably in around 2014 or so, and I'll show you some graphs in a minute which depict this. So the point I'm making is sometimes while it was slow to react, we have this upon us. This slide gives you a sort of historical basis. Also, as you will see in the graphs, and this covers a number of years ending, I think, about 2017, you do see to the right of the graphs on the vertical slides, the bars, that there is a decrease in prescription opioids, and that is so. We have seen that steadily. There are a number of reasons. There are abuse deterrent formulations, there are PDMPs, there are local legislatures passing laws against pill mills, certainly in Florida, but it does show a decline. Here's the other problem. While that decline is happening, you now see the rise in heroin and fentanyl, and you now see a more current shift with fentanyl and methamphetamine, which is certainly a deadly combination. It really represents a sort of updated version of the speedball effect that we would see in the 1960s and 70s. Certainly when I entered as a counselor in a methadone treatment program in New York in 1974, the speedball effect was fairly common. This represents something altogether different. And you have wily drug dealers, as many of you probably know, which are providing both fentanyl and methamphetamine in a tablet with the stamping indice in it. And then they also provide Narcan kits too, and say, look, if you find yourself getting into trouble, have a friend with you that can administer the Narcan. So it's a sort of all-purpose drug dealer. The summary of the radar system, and these are data that have a mosaic of reporting from narcotic enforcement to treatment folks as well, is that prescribing drug use is going down, and methadone as a prescription for pain is decreasing. This has nothing to do with methadone and OTPs, and buprenorphine use is absolutely increasing. And the abuse of prescription stimulants and other non-opioid drugs are increasing dramatically. And this is an important principle. Anything that restricts the opioid drug supply will increase heroin abuse. This is a finding. This is not a sort of come upon finding that's new. This has been carefully researched and evaluated. And certainly illicit fentanyl is now becoming one of our major policy problems. These are the OTPs throughout the United States. So there are about 1,700 of them now. The only state that does not have an OTP is Wyoming. And that's a curious reason for why they don't have it, because we know from the states adjacent to Wyoming that Wyoming-based residents cross the border to access treatment in the adjacent states. From my point of view, in a public health epidemic as we have right now, there's no reason not to provide availability to treatments for opioid use disorder. We have proposed to 2 different federal agencies recommendations that could help change this and provide increased access to care in rural and underserved areas of the United States. One, we've asked SAMHSA to develop telehealth, telecommunication guidelines for OTPs. Next, we've asked them to support the building of new bricks and mortar satellite medication units, which could be dispersed in rural and suburban areas and connect back to the 1,700 OTP hub sites. Third, we've asked the DEA to accelerate their release of mobile van regulations. They've been working on this for several years. We have certainly encouraged this, and we believe that they will be coming out very shortly, hopefully in the next 60 days or so. It had to go through DOJ clearance. It got it. It's now going through OMB clearance, and we think they will get that too. The mobile van issue connects to corrections in an important way. In fact, the delay in the release of the guidelines was to add in a section recognizing that the vans could be used in transporting medication from an OTP site into the correctional system site directly. And they added the section so this can be promulgated. And we've been working with the DEA recently in developing guidance to OTPs on how medications can be safely transported into residential units, whether it's a skilled nursing facility or a correctional environment. The point is, from a policy-making perspective, these are critical, and our board of directors, Wendy Looker represents your state to our board will be meeting on March 5th in Washington. We're opening a new door to the Department of Agriculture. The Department of Agriculture has funding and an interest in increasing access to OTPs in rural and underserved areas. I remind you that the Department of Agriculture has a long history in providing support to rural communities. And from this point of view, they have funding that we could tap into, and that's what we've determined on March 5th when we're next in Washington. And that becomes a group that could work in conjunction with the Substance Abuse and Mental Health Services Administration. So the problem of an opioid crisis is clear. You've heard this for 2 days, and I'm sure you've absorbed a lot of information. But it's also provided policymaking opportunities. When I presented these data, which I referenced to 2010, I was struck by what I perceived to be at the time not a better understanding. In fact, one of the federal officials looking at me said, "We have a very broad policy forest, Mr. Parrino, and what you're presenting is a very small part of the forest." I said, "Well, let me explain something to you. When my part of Sherwood Forest catches fire, it's going to break through all of your policy firewalls, and it's going to engulf you," which would happen, as you know. And so I think that the issue here is paying attention to data as it's developing. And I will say that I'm very encouraged by your participation in this conference, because from my point of view, it signals a definite turning point in how people, inmates with opiate use disorder, can be effectively treated in your custody and then transferred in a warm handoff, so-called, into treatment. This was the first article, and you'll note the editor was sort of had a sense of humor, I guess. I wrote an article 20 years ago. This was published in American Jails magazine. It was about the Rikers Island treatment program in New York City. The green lettering and the purple background, I think, was their idea of perhaps putting a sort of like backdrop to what they perceived methadone to be at the time. Just to be clear, methadone has never been in a purple pill form. But the importance of the article was it was one of the first times an article of this kind was published in a communication for corrections. And while 20 years ago, I can tell you, there's been a long history, and now you see a very active sort of movement. And there's a history. We developed this paper, and you can go to our website. My contact information is in the last slide. This is a fairly detailed fact sheet on the medications that are used to treat opioid use disorder, issues around it, facts, myths that are addressed, and I hope settled in this. It's been circulated for the last several years. We wrote this at the behest of the Substance Abuse and Mental Health Services Administration. This comes from New South Wales, the issue of the opioid substitution treatment in prison and post-release, the effects on criminal recidivity and mortality. This is what Linda and colleagues are finding in the Rhode Island Department of Corrections at the present time. And I really am grateful to the leadership in the Rhode Island Department of Corrections for being such cooperative partners. This is an interesting paper. Again, if you would like to have access to it, I'm happy to get it to you. I've already referenced this. This comes out of Brett Gibson's group, the National Commission on Correctional Health Care, from October of 2018. From my point of view, a landmark document. Provides lots of ways you can address this through different sorts of patterns, different models of care. We think this is a great event. I spoke at their conference as this was being released. I'm grateful to Brent and his associates for being such great partners to us, and will continue that work in the future. But this is a great document. You should read it if you haven't yet. This talks about the Rhode Island system you've got, CODAC, and I'll just go through a number of these publications which reflect interest in this work throughout the country. These with all the partnering organizations in Massachusetts to get medication-assisted treatment in the jail and prison system. This talks about the civil rights case in Washington State about having medication available. This goes to the issue of Arizona and their programs to prevent opiate withdrawal and jail deaths. This goes on to Santa Fe. Again, their interest in doing this. And I'm going to talk about this for a bit. This is Congresswoman Custer's bill. This bill will provide $50 million to the Department of Justice for a 4 consecutive year period in order to increase access to medication-assisted treatment in corrections. The bill has been introduced. I actually met with her staff this past Tuesday evening when I was just finishing up my work in Washington, and we have asked that they change the language of this bill, which has a very complicated section on you should use one agonist or a partial agonist-antagonist, or use some sort of pure antagonist. And my recommendation, and we're not alone in this with others, is to basically say, use the federally approved medications to treat opioid use disorder, because that may change. And I understand that depending on the manufacturer, you promulgate one medication. From our point of view, each of the medications has value. These are not like antidepressants. We don't have dozens of antidepressants. We have 3 primary drugs that have been approved by the Food and Drug Administration. They should be actively used in a way that is consistent with the needs of the individual patients. There is no broad-based issue, and the patient should absolutely be involved, whether they're inmates or they're in an outpatient treatment setting, in determining what the medication should be. That is the bond between a patient and a clinician, or the series of clinicians that are treating the patient. From my point of view, and I spent 18 years of my professional life working in an OTP in New York City, and I can tell you that the relationship between provider and patient is a very important one. And for those people who are saying, well, maybe we don't really need the protections of confidentiality, we're in a new age of electronic caregiving, I got to tell you, it's not by accident that the patient advocacy groups in the United States want to preserve the patient confidentiality protections. We support that, frankly, as do my colleagues and the Legal Action Center. Why? Because we know all too well that once certain parties learn of a person taking methadone or buprenorphine to treat their disorder, that comes up in child custody cases in courts. It comes up as an issue with child protective workers and services. It comes up with employment. Such individuals, once revealed, cannot obtain health insurance, life insurance, or disability insurance. These, ladies and gentlemen, are bedrock realities. Pay attention to them, not from the point of view of a policymaker, from the point of view of the patient as the human being. As the point of view of the individual who makes a struggle but lifetime-changing decision, I will cross the threshold of a treatment program. I want to get treatment for my problem, for my illness. We must do everything we possibly can to preserve and protect that. If we put this change into effect, we now put into our patients' heads a sort of question or guess. How long can I stay in treatment, and how long do I fear really losing my patient protections? And with all due respect, and I know that the Association of State Attorneys General wrote a letter to the congressional leadership last summer supporting this change. Now, I understand why they did that. And the view is, and somebody from Oklahoma City made it clear to me, said, well, we'd like to cross-match information that might go into PDMPs. And we'll cross-match that against outstanding warrants. And then we can get a squad car to go in front of the clinic and then wait for the patient. And I had to explain, this was not the purpose of the PDMP. You don't want to pervert the original purpose of that. And to the issue of, well, how will physicians know that a person is getting methadone if they don't disclose it to us and we don't check the PDMP? It's called toxicology testing. There's lots of rapid-fire toxicology tests that can absolutely and objectively determine what is in the patient's body. This does not have to be an arch conflict of great philosophic proportion. What does this mean? We are disempowered as physicians. Yes, it was said before, what's the risk? What's the benefit? I think, frankly, the risk of losing patients, the risk of preventing patients from entering treatment is an intolerable risk. There are ways to get at the information, even if the patient chooses, for whatever reason, not to disclose it. And let me tell you, some of those patients have their reason. I've seen it. And I'll tell you one story to this effect in the few minutes left of my time. When I was a young clinician working in an OTP, one of our pregnant patients delivered. And the hospital didn't have methadone on the formulary. So I brought over 5 bottles of medication because she had a cesarean and she was going to stay there for a while. And I remember the nurse coming in and throwing the bottle of the take-home against her stomach and said, here, honey, feed this poison to your baby. Now, ladies and gentlemen, no matter what you think on the scale or what your attitudes are towards individuals who have gotten into opioid use disorder, and I guarantee you, because I've worked with so many patients over the years, that's not exactly a career path that's chosen. There are no segmented times that says, I'll begin with this drug, I'll elevate to this drug, I will begin injecting this drug, and there's going to be a time in my near future where I will become a full-fledged heroin-using individual or fentanyl using. It is not a career path of staged and graduated approaches. I'm not saying that the individual doesn't bear a sense of responsibility, and that's not my point. I feel that we should all be responsible and accountable for what we do as adults, and I believe that strongly. And I think our policy should reflect that reality. On the other hand, to this debate about, well, do we have quality support services when medications are used? Yes. And then someone said, well, I think the jury is still out on that. I said, well, how do you then explain 50 years of research which explain patient outcome data? The jury is in on this. The verdict has been absolutely delivered. I said, and the issue was, well, we're in an opioid use epidemic. I said, I understand the problem we're in. I've been doing this work for 40 years, and I've learned a great deal about the dynamics of the treatment system, how you engage in treating a patient, how you deal with the patient's family, the community that the program dwells within, the regulatory authorities that we work with. It's a holistic affair. We must also be able to clearly define what the success is. How do we retain a patient in treatment? And in my closing remarks, I'll just say there was one paper that had a particular influence on me. Dr. John Ball and his colleagues, interestingly enough, criminologists by training, had a NIDA grant to do 3 years of training and 3 years of evaluation. What they found was that 80% of the patients would relapse to using pre-treatment narcotics within 1 year of ending treatment, even though that would be ending voluntarily or involuntarily. 80% relapsed within the first year. You could say anything you want about weakness of will or not having strength of character. The bottom line is that we're dealing with a chronic and relapsing condition. That's it. And the better you link the patient to effective treatment, the greater likelihood that patient will have of sustaining their sobriety, based on William White and Lisa Moyatora's workbook, which talked about the value of being in recovery also means being in treatment with medications. That the definition of recovery does not necessarily need to embrace lack of medication. So we must be careful not to say that one's recovery is superior to another. That's sort of Orwellian Animal Farm descriptive information. It's not useful in this discussion. So with that, I know that you have other things to deal with. I realize you've been here for 2 days. I realize that you have absorbed a great deal of information. Understand that what we're trying to do is reverse the course of a tragic epidemic. And this epidemic will take on new shape in the coming years. Typically in the United States, and this is certainly true over the last 120 years, opioid epidemics are quickly followed by stimulant epidemics. This is the way it is. There are explanations for that with brain chemistry issues, the fact that typically a person wants to feel some sense of being alive and stimulated after being a central nervous system depressant with opioids. So we think that's coming, and you're seeing that rise with methamphetamine. So be vigilant, gear your systems up. This will move, it will change, and you saw the slides I showed you earlier today. So please keep that in mind. There are many partnerships developing. I frankly am optimistic. While I'm old enough to have a nice cynical perspective about how organizations, federal agencies, federal to state agencies function, because I've seen it for 40 years. Some of it works well, and some of it's a little strange and dysfunctional, frankly. And I know that some agencies don't necessarily like to communicate with one another. We provide encouragement for that interagency communication. We serve as facilitators in that regard. But ultimately, we're all collected in this room, regardless of walk of life, of background, in order to effectively treat the people that we serve, whether those people are in correctional environments or treatment facilities. That is a tie that binds us all together inextricably. And I encourage you to keep that philosophy in mind. These people can be treated, there's no question. There are effective medications as long as they are used in methods that are based on evidence, based on research, with good clinical practice. And when someone said, well, sometimes the counselor lacks compassion or doesn't have training, well, in that case, then you have to train the counselor or get a new counselor. Ultimately, these are not impossible tasks, ladies and gentlemen. They are not. And I've got 40 years of history to demonstrate that. We've done a great deal of work, from my point of view, This issue is one of the real critical policy issues of our time. It will take years to develop. So thank you again. Thank you, Catherine. Thank you, Lori. I appreciate the support you've provided. The ATTCs are a valuable network, and in the place I was at in Washington, you guys were cited by the United Nations and WHO, who will turn to you as future partners in the dissemination. So thank you all. Thank you for attention.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.